At the bottom of page 120, the book talks about the Schilling test, and the Schilling test is really not really done anymore. I tried ordering one 20 years ago, and they wouldn't do it. We don't do those anymore. Anyway, but it's a historical interest, and if you understand how the Schilling test works, then you understand B12 deficiency, so you have to understand how the Schilling test works, okay? So basically what happens with the Schilling test is that in a patient to whom you're going to administer the Schilling test, the first thing that happens is that they get a loading dose of B12 administered parental. They get a loading dose of B12 intramuscularly. And the reason that you do that is you want to saturate all of the B12 binding sites in the body. You don't want there to be a lot of B12 avidity in the body. You want the binding sites to be saturated. You'll see why in a second. Then you give them an oral dose of radioactively labeled B12. And you collect urine. And you look for the appearance of the B12, the radioactive marker, in the urine. Now, in order for the B12 to find its way into the urine, it has to be absorbed through the bowel, right, through the ileum, the small bowel, into the bloodstream, and then it finds its way into the urine, the kidneys of the urine. If it's not absorbed, then the radioactive tracer is going to come out. It's going to come out in the stool, and there's not going to be any B12 in the urine. So, part one of the Schilling test is this is what I just described, and a normal result would be to find a normal amount of radioactivity in the urine. If you don't find normal results of normal amount of B12, radioactive B12 in the urine, then that means that there's a problem with the absorption. And you don't know what the problem is yet, but you know that there's a problem with the absorption. Okay? So, for example, the patient might lack intrinsic factor, that they have pernicious anemia, or they might have disease of the ileum. Maybe they have extensive Crohn's disease, or maybe they've had surgery or something, and they have dysfunction of the mucosa that's responsible for the absorption of the B12/intrinsic factor complex. So you do part two of phase 2 of the test. Again, you load them with B12, and this time you administer B12 and intrinsic factor, B12 complex with intrinsic factor. And you look for the appearance of the radioactive tracer in the urine. So if you find a normal amount of B12 radioactivity in the urine, it means that this person was capable of absorbing the B12 intrinsic factor complex. And so then you would conclude that the problem was what? So if part one was abnormal and part two was normal, the diagnosis is pernicious anemia, that they're not making intrinsic factor. Okay? Of course, it's also possible that when you look for the appearance of the radioactivity in the urine, you will find it even up to stage 2. And that means you're dealing with a problem of the terminal ileum, where the B12 is absorbed.
So all pernicious anemia is not due to a lack of intrinsic factor. All of B12 deficiency is not due to pernicious anemia, because if you have a ileum issue like what?
Right. The cause of B12 deficiency is multiple causes of disease. Certain intestinal parasites that cause B12 deficiency. Bacterial toxins, something. B12 deficiency is not all B12 deficiency is pernicious anemia. Pernicious anemia refers to B12 deficiency that's the result of autoimmune destruction of the parietal cell. So they get atrophic gastritis in association with the megaloblastic anemia, and of course they're at risk to develop also of neurological symptoms. So if we don't do, yeah.
So B12, unlike iron, is much more common to have decreased or deficiency being decreased intake.
Yeah. Yeah. So since we don't do children tests anymore, then the question is, well, how do we make the diagnosis? What tests do we do for pernicious anemia? How do we make a diagnosis? And since it's an autoimmune process, what you look for are anti-intrinsic factor antibodies. So these are antibodies to the intrinsic factor, and anti-parietal cell antibodies. And just for your own edification, the anti-intrinsic factor antibodies are 50 to 84% sensitive and 100% specific for pernicious anemia. Anti-parietal cell antibodies are less sensitive and less specific. So if you can only order one, order the anti-intrinsic factor antibodies.
Which one would tell you if it was a terminal organ problem?
If you get an abnormal result in both part 1 and part 2.
With the anti-intrinsic and anti-parietal?
No. These tests are looking for pernicious anemia. So those tests are going to be positive, are going to be abnormal in patients that have pernicious anemia. If you suspect mucosal disease, you remember that algorithm I showed you before for malabsorption? I mean, you could do a number of things. You could do imaging studies, and you could do a biopsy if you had to suspect mucosal disease. The next category that they talk about, and I'm on page 122 now, are anemias that are the result of bleeding and hemolysis. And generally, again, that's the pathophysiologic category. The morphologic category that corresponds to that is generally going to be normocytic anemia, normocytic. So the differential diagnosis of these bleeding and hemolysis normally cause a normocytic anemia. With a couple of provisos I'll give you in a second. The differential diagnosis of normocytic anemia is going to include all causes of anemia early on. So all causes of anemia early on can be normocytic. Blood loss, hemolysis, chronic renal failure, and things that suppress the bone marrow. Now, when I said that these normally produce a normocytic anemia, but you have to understand a couple of things. If the bleeding is chronic and the patient develops iron deficiency anemia, then you'd expect microcytic anemia, right? We're talking about an acute bleed, okay? Acute bleed. If it's chronic, you're going to develop iron deficiency anemia, and then it's not going to be normocytic anymore at some point. And then the other thing is that with hemolysis, remember that if there's a brisk reticulocytosis, reticulocytes are bigger than normal cells, so they might actually have a component of, they might actually have cells that seem a bit on the large side. One of the other things that you look at when you look at the CBC is the RDW. It tells you about the distribution of sizes of the red cell. So remember when you're looking at the slide, if you're actually looking at a slide, you can get an idea for whether the cells are all of the same size, if they're uniform. And so if you see some small cells and some big cells, you'll see that there's a spread. And you have to then take into consideration that what the machine is reading is the average size of the red cell. Okay? Well, the RDW gives you that same information. Okay? It tells you about the spread from the smallest red cell to the biggest red cell. Okay? So the RDW is something that you can look at to see if the cells are all of uniform size or if there's a large spread. It's telling you about the variability in the size of the red cell. To the extent that you're dealing with a lot of variability in the size of the red cells, let's say you have somebody that the MCV is normal. But then the RDW is, well, let's say it's normal, but it's sort of like right on the edge. And then the RDW suggests that you have a wide range of red cell size. So then you have to keep in mind that you might be dealing with, for example, a couple of different types of red cells. Maybe you have reticulocyte presence that are falsely raising the MCV. Okay? So by looking at the RDW, you get an idea for whether you're dealing with a uniform population of red cells or whether you're dealing with a population of red cells that have different sizes. Okay. So let's talk about causes of, we've talked about bleeding. A couple of things. Let's talk about hemolysis. Okay. Hemolysis refers to destruction of the red cells, and it can happen either because of problems with the red cells themselves, or it can happen because of problems that are external to the red cells, extracorpuscular defects. So let's talk first about the extracorpuscular defects that are associated with hemolytic anemia, and we've alluded to some of these already. So, for example, at the top of page 122, they talk about the role of hypersplenic hyperactive spleen. We talked about that when we talked about portal hypertension. Remember that? And we said that the patients that have portal hypertension can develop splenomegaly over active spleen, and they can develop hematological problems as a result of that, including the presence of anemia. They can also get some full white cells there, platelets there, that contributes to the thrombocytopenia in those patients. They talk about other extracorpuscular defects are intravascular trauma to the red cells from what's referred to as microangiopathic hemolytic anemia. And an example of that is DIC, or disseminated intravascular coagulopathy. So what's happening in that is that you have let's say that this is the lumen of a vessel. That's the lumen of the vessel. With DIC, you get intravascular coagulation of protein. Okay? And so what ends up happening is that you get this sort of a mesh created in the lumen of all these protein fibers. Okay? And if you're a red cell, you're coming along and you're heading right towards that thing, so the blood's pushing you, and it's going to basically push you right into that web, and it's basically going to shear the red cell. Okay, it's going to tear the red cell apart. It's going to act like raisins. Okay, so it's intravascular trauma to the red cells because of the intravascular coagulation, the DIC, disseminated intravascular coagulation, microangiopathic hemolytic syndrome. And they point out that one of the things that you'd expect to see if you looked at a smear, is you see abnormal shaped red cells, including helmet cells. So let me show you that. abnormally shaped red cells. You can see that some of them have actual names associated with them. So this is here you have a helmet cell because it looks like a military helmet. Okay, one cell, whatever. There's different names. The important thing to recognize is that you get abnormally shaped red cells because of the trauma to the red cells. Okay, and you know, you can see PIC, for example, in sepsis. PIC can develop in patients that have sepsis. PIC can develop in patients that have malignancies. So you'll see this when we'll talk more about PIC, or when we get to the coagulation cascade part of the chapter. The other causes of hemolysis are intracorpuscular, and the red cells are relatively simple animals, which they depict that on page 123. So there's a membrane, there's hemoglobin, and then there's the metabolic enzymes. Okay, so this is a simplified version of the red cell. So you got the membrane, you got the hemoglobin there, and then you got the enzymatic machinery of the red cell. So we'll talk about each of these components in turn. The things that can cause, again, we're talking about intracorpuscular defects that are associated with hemolysis. So the first one that they talk about is sickle cell anemia, where you have a mutation in the DNA that goes to the protein chain, and that results in cells that sickle when they're in a hypoxic environment. And thalassemia is another cause of the same thing. Remember that thalassemia is associated with hemolytic anemia, but in that case it is glycocytic. Besides abnormalities in the hemoglobin, you can also have a membrane abnormality, and the most common membrane abnormality that's associated with hemolysis is hereditary stereocytosis. And in hereditary stereocytosis, what happens is that you have a decreased mechanical stability of the red cell. It's the most common hemolytic anemia due to a membrane defect, hereditary stereocytosis. And these patients can have anemia, jaundice, and splenomegaly. And the treatment is going to be involved splenectomy. So let me ask you a question. What kind of jaundice do you think they have? Unconjugated, indirect, right? That's important. You have to, when you come across something like this in the reading now, you've already talked about jaundice. Now you have to ask yourself, okay, what kind of jaundice is it? Why is it that way? Make sure you satisfy yourself that you understand why the patient that has hereditary stereocytosis has an indirect hyperbilirubinemia. anemia. Okay? And then the third cause of hemolysis would be a disorder of the metabolic enzymes of the red cells. And the one that's paradigmatic is G6PD deficiency. So patients that have G6PD deficiency are prone to the development of hemolysis under conditions of oxidative stress. So, for example, they give you infection. Certain drugs, including sulfa drugs, will produce hemolysis in those patients. And some people have favism, and they develop. Anybody have favism? Anybody eat favism? Huh? They're good. They're really good. So anyway, but some people can't eat them because they cause oxidative stress and yeah. Say it again. What's the systemic disease? Yeah, well, what do you mean they would have problems everywhere? Oh, I don't know. I guess B6PD is present in other cells as well, I guess, but I guess it's a great clinical form with respect to the red cell. I don't know if they have other problems. They have other. Look it up right now. I don't know. Does anybody know what's up their head?
What? No. I